Welcome to the Canadian Association of Emergency Physicians webinar. Thank you for joining us. The title of the presentation today will be The Discovery of Traumatic Brain Injury Biomarkers, the Journey from Bench to Bedside. I'm pleased to present with you, and this is through sponsorship with Abbott. I am Dr. Chris Devlantes. I'm an emergency physician in the United States, practicing emergency medicine, and also the Senior Director of Global Medical and Scientific Affairs for Abbott Point of Care Diagnostics. Dr. Papa will be presenting. Dr. Linda Papa is an emergency physician and Director of Academic Clinical Research for the Orlando Health Orlando Regional Medical Center, which is a level 1 trauma center in Orlando, Florida. She is Professor of Emergency Medicine at the University of Central Florida, Associate Professor of Medicine at Florida State University, Adjunct Professor of Emergency Medicine at the University of Florida, as well as Adjunct Professor of Neurology and Neurosurgery at McGill University. Dr. Papa holds a master's degree in clinical epidemiology and community medicine and has worked closely with various groups and agencies across the country to improve outcomes and advocate for patients with trauma and traumatic brain injury. She was part of a task force in Florida that helped pass Florida's Youth Athlete Concussion Bill, HB 291, that provides concussion guidelines to ensure young athletes are adequately evaluated during sports. She is the recipient of several National Institute of Health, or NIH, and Department of Defense grants to improve the care of patients with traumatic brain injury, or TBI. Most notable was her pioneering work in the discovery and validation of the very first FDA-approved blood test for TBI using biomarkers GFAP and UCHL1, a journey which began over 20 years ago with a pilot study she designed and conducted in the emergency department on a shoestring budget. This study led to the first publication demonstrating the association of these biomarkers with traumatic brain intracranial injuries after mild TBI back in 2008. She serves as a scientific reviewer for several different federal funding agencies and has published approximately 400 original peer-reviewed research articles, book chapters, and abstracts. Dr. Papa and her emergency medicine colleagues in Orlando were actually the first in the world to clinically implement the whole blood point of care ISTAT TBI test using GFAP and UCHL1 biomarkers in adults presenting to their emergency department with mild TBI. Dr. Papa is actively involved in evaluating the impact of the TBI blood test in clinical practice, further defining their journey from bench to bedside. So with that, I'll welcome Dr. Papa and turn things over to her for this educational webinar. Thank you.
Thank you, Dr. Devlantes. So today we're going to talk about the journey of these biomarkers from bench to bedside. I have no disclosures, which means I'm either a very ethical researcher or I'm a terrible businesswoman. So the objectives of today's webinar is to describe the journey of these TBI biomarkers, to describe how a TBI blood test could actually change clinical practice in patients with mild traumatic brain injury, and to describe the clinical implementation. So this is why we do this work, right? TBI is ubiquitous. It affects all walks of life and all ages. It's a very significant disease, 3 to 5 million ER visits in North America each year. The majority are mild and almost 1 million are children. So this is a significant problem. So just for the purposes of the webinar, I would like to clarify that a concussion is a mild traumatic brain injury and vice versa. Mild traumatic brain injury is a concussion. So these terms will be used interchangeably. They're basically the same thing. So today I'm going to tell you a little story. It's not this story, but it's a story that has lots of science, a hint of science fiction, and a zing of comedy. Throughout this 25-year journey of biomarker discovery, I have met some larger-than-life characters. No goblins, no mermaids, a few trolls, maybe some nasty witches, but behind the whole process, there was a little bit of magic. So how it all started was in the early 1990s. I was an emergency medicine resident at McGill University, and there were two great debates at the time. The first one was, should we be using this new cardiac biomarker called troponin to evaluate patients with chest pain? And the second one was, which patients with mild TBI actually need a CT scan? So at the time of my residency, there were no clinical guidelines to help us decide this. So the management in the ED at the time was do a Glasgow Coma Scale score, a good neurological examination, and maybe a CT scan based on clinical judgment. And so we know that the Glasgow Coma Scale has its limitations. It's a great triage tool. It was created in 1974 by Graham Teasdale and Brian Jeanette at the University of Glasgow. And it was intended for caretakers to be able to communicate how patients were doing after a TBI. And so generally mild TBI is considered a Glasgow Coma Scale of 13 to 15. However, we know that it can be influenced by drugs and alcohol, by medications, if patients are having seizures, trauma, other distracting injuries, hypotension, hypoxia. So the GCS score has quite a few limitations in terms of its accuracy. So next, in the late 1990s, I'm actually an emergency medicine fellow at the University of Ottawa, and I'm working with the guru of clinical decision rules, Dr. Ian Steele, and learned so much at that time. But at that time, the guidelines came out. Finally, we had guidelines. In 2000, Dr. Hidell published the New Orleans Criteria, New England Journal of Medicine. And then in 2001, Dr. Steele published the Canadian CT head rules. And so now we actually had some rules. So the New Orleans Criteria brief summary, again, the CT head rules, which I'm sure you're all familiar with. And then the rules work really well. The New Orleans Criteria and the CCHR both had great sensitivities. The specificities were a little bit different. However, the New Orleans Criteria had a much lower specificity, 10 to 20%, compared to the CCHR, which had sensitivities going up to about 50%. So really, they worked well. We had these new guidelines. So the management of mild TBI changed. The GCS score, the neurological exam, now the clinical decision rules, and then we had that to help us decide whether a patient needed a CT scan. So we were making progress. So this was great. This was really, really helpful. However, there was still something missing. So there was some variability in interpretation of some of the clinical decision rule criteria, for example. In other words, trauma above the clavicles, how exactly to interpret that. Getting a clear amnesia history was sometimes very difficult. Sometimes the history or the mechanism of injury wasn't very clear, or patients who had seizure syncope prior to the event were often excluded from the decision rules, and anticoagulant patients as well. So there was still some information that we needed to help us make these decisions. So here I am, I'm all grown up. It's the early 2000s. I'm an emergency medicine attending physician at the University of Florida, and I'm using biomarkers every day. It's a common thing. Almost every organ in the body has a biomarker. And so I was scratching my head and I said, well, why don't we have a blood test for brain injury? And so that was on my mind. And so I worked with two great neuroscientists there, and we had an idea. And that's where our journey of biomarker discovery actually began. We started with an idea. So just like the flip phone was inspired by Star Trek, we had our idea. Wouldn't it be great to have a handheld device, a test, a TBI point of care test that could help us to determine the severity of injury after a TBI? And so that was our vision, something like a glucometer. So that's what we were hoping to achieve. And so we have this great group of scientists and clinicians. We all got together and we started discussing how we were going to move forward. And so a very, very interesting process, great comedy of errors. And the work began in the early 2000s. We had very little funding. I was working on a shoestring budget. I was enrolling patients in the emergency department, asking, patients if they would kindly give us a sample of their blood so we could look for biomarkers. And so the journey began. And the evolution, we used, this was our clinical model, essentially, from bench to bedside. We started with a rodent model, and then we moved on to the human model. And our rodent model was essentially, we started with a biomarker called UCHL1, ubiquitin C-terminal hydrolase L1. And this was actually a histologic marker. So if somebody wanted to look under the microscope and wanted to stain for neurons, they would stain for this protein called UCHL1. And so as you can see, UCHL1 is very plentiful in the body, particularly of the neuron. And so we found that in rats, there was a significant amount of this in the rats who had a TBI. But of course, we were not doing the rats any favors at this point. We needed to move this to a human model. And that's where we moved to severe TBI. And severe TBI patients often have significant injuries that cause swelling and compression. And so a drain will be put into the ventricles to try to remove some of the cerebrospinal fluid so that to reduce the pressure. And this fluid is often thrown out. So we designed a protocol, took this fluid and examined for the biomarkers that we had looked at in the rat model. And lo and behold, we found that UCHL1 was also present in severe TBI patients. And it rose quickly and then gradually declined. And it was higher in patients with more severe injuries, which is exactly what you'd like to see. And then in patients who had complications over the course of a week after their injury, also had much higher levels through their entire week stay. And so we knew we were onto something. This was, something very promising. But we knew that it wasn't practical to only measure this in CSF. We needed to have a more viable solution or biofluid that we can measure these biomarkers in. And so we took a look at the biomarkers in the CSF and the serum, and we correlated them. And we found that there was a really beautiful correlation between the CSF levels and the serum levels. And so we knew that we could find these biomarkers now in the serum in severe TBI patients. And so we were ready for our next step. What about mild and moderate patients, mostly mild patients? What could we find in them? So at this point, another marker becomes really, really interesting. And that marker is called glial fibrillary acidic protein. And the interesting thing about it is that it comes from the surrounding cells around the neuron, the astroglial cells. So you have UCHL1 that's in the neuron, and then GFAP, which is part of the supporting structure. So you have two neuroanatomical biomarkers here that you're looking at. And so that was our next project. So in the mid-2000s, we conducted another study, mostly in mild TBI patients in the emergency department. This was the shoestring budget, collecting samples, on shift when we had the opportunity and looking at the biomarkers. And I remember looking at the results one night and analyzing the data, and I was just flabbergasted. I couldn't believe the correlation with these biomarkers and the severity of injury, even in the mildest of patients. And so that was sort of our eureka moment. It's like, oh my God, these markers work in mild traumatic brain injury, and they tell us how severe the injury is. And so we were really excited, and we published the first paper in 2008. And then we had several publications following that. And so you can see the results from these studies that we did is this beautiful graded response of the biomarkers, both of them actually, depending on the severity of injury. So we had patients who were normal volunteers who had no injury and very, very low levels of both biomarkers. And then we had patients who had orthopedic injuries with no head trauma, a little bit of an elevation. And then the patients who had a traumatic brain injury from mild to a more moderate injury, you can see the biomarkers just climbing beautifully, just a beautiful incremental increase in both of the biomarkers based on the severity of the injury. And again, very low levels in patients who had no injury. So the biomarkers were doing exactly what we wanted them to do, is to give us an indication of severity. And so you can see here the traumatic intracranial lesions had much higher levels of both GFAP and UCHL1 than those who had no lesions. And so this is sort of where we hung our hat, and we thought this is where we're going to make a difference. And if you look at the sensitivity and specificity, both biomarkers are very sensitive. The specificity for GFAP, however, is a little bit higher than that of UCHL1. And we also looked at patients who required a neurosurgical intervention. So what about the patients who have a TBI, but who will eventually require neurosurgical intervention? And you can see that the levels of these biomarkers are much higher in patients who actually required a neurosurgical intervention in the first 7 days after injury. So another indicator of severity. And so here we have these two proteins, both were histologic markers, now have been repurposed to help us determine the severity of a TBI. And so we looked at patients in multiple trauma, and both markers worked really, really well, even in the face of multiple trauma. So our next step was, well, what about the time course of these biomarkers? When can we actually use them to help us determine severity of injury? And so what we did is we took samples, 20 samples actually, over 7 days. There was some inconsistencies in some of the studies that were coming out at the time. They were measuring biomarkers at 24 hours, 48 hours, some at 12 hours. So we wanted to take a closer look at what these biomarkers looked like over the first 7 days after injury. And so we sampled the biomarkers, and we found that both GFAP and UCHL1 had their own temporal profile. So GFAP rate got up early, so elevated early, and then peaked around 20 hours and gradually came down over 3 days. And then UCHL1 peaked really high, very, very early after injury, within 15, 20 minutes, and then quickly came down within 8 hours. And so 2 different temporal profiles, one that comes up really early, one that peaks a little bit later. So really interesting temporal profile. And what we found is that the levels of the biomarkers over the 7 days also correlated with whether a patient had lesions on a CAT scan. And so you can see that in terms of how many picograms that these patients had, very low levels of biomarker, maybe 50 picograms in patients with no CT lesions. And then with patients with lesions, you're talking about 2,000 picograms, 3,000 picograms, really, really high levels in patients with lesions. And so the same thing with neurosurgical intervention. We're talking about levels of 6,000, 7,000 picograms in patients with neurosurgical intervention. So really, really impressive the way these biomarkers were elevated really early after injury. And you can see GFAP is pretty accurate for the full 7 days, and UCHL1 accuracy is good probably within the first 20 to 24 hours. We also took a look at patients with and without TBI, so patients who had other injuries but no evidence of a concussion or a mild traumatic brain injury. And we found that the biomarkers, even though the levels were much lower than those who had positive CT scans, they actually had significant elevations. So we could show a distinction between patients with and without concussion in our mild TBI cohort. So that was very exciting and shows promises for uses in the future. We also looked at patients who had what they call subconcussive injuries. In other words, patients who hit their head but have absolutely no symptoms. And we compared those to patients who had a concussion. And there were some elevations. So even if somebody hits their head, doesn't have symptoms, there still is a little elevation of the biomarkers, just not as much as in patients with concussion. So all really, really interesting results. And so the question then was, well, how soon after injury can we actually see these biomarkers? And so we just took a look at this in pre-hospital patients within the first 30 and 60 minutes of injury. And we found that the biomarkers elevated actually really early, within 30 minutes. I mean, we could see elevations as early as 10 minutes to 15 minutes after injury. So these biomarkers come up within minutes of injury. So the implications of this going forward is pretty large. We can do so much when we know that the biomarkers are sensitive really early on after injury. And you can see sensitivity, 98% with a specificity of 34% within 30 minutes of injury. So this is really exciting. I mean, this gives us a lot of information in terms of how we could use these clinically. So for many years, I did this talk about the biomarkers, and there were really no FDA-approved biomarkers for the longest time until 2018, which is when the first blood test for these biomarkers was FDA approved. It was approved only in adults in mild to moderate traumatic brain injury within 12 hours of injury. Unfortunately, it was not practical to use. It required specialized equipment to run the assays. It took roughly 4 hours to process. So it really was impractical for us to use clinically. And so we were still stuck at that point of care TBI test. So we'd gone through the rodent model, the severe TBI, the serum in mild TBI patients. Now we wanted a point of care device. So we wanted to take a look at these biomarkers in the realm of clinical decision rules. So how do these biomarkers perform relative to the clinical decision rules? And so we did a study in our emergency department where we did a prospective study. We actually went to the clinicians who were seeing these patients, and we asked them to fill out the Canadian CT head rules, the New Orleans criteria, and the Nexus 2 criteria, and tell us what they thought about how these decision rules apply to their patients. And then we also took a blood sample. So we did this in real time. So this is a prospective evaluation of these clinical decision rules. We didn't look back in a database. We actually prospectively took a look at the decision rules relative to the biomarkers. And of the 3 decision rules, the Canadian CT head rule had the best sensitivity and specificity out of the 3 rules. And then when we looked at the sensitivity and specificity of the blood test, the GFAP and UCHL1 combination, what we found was also very high sensitivity with a specificity of about 25%. So very, very good performance for GFAP and UCHL1. And then if we combined the Canadian CT head rule with the biomarkers, we found an increase in the specificity. So an improvement from 25 and 33% specificity all the way up to 46%. So the biomarkers added an additional layer of specificity to the existing clinical decision rules. And so they were complementary. So the clinical decision rules were complemented by the biomarkers. And so we asked our clinicians in our emergency department, we said, well, what would you think if we had a blood test for traumatic brain injury? And 86% of my colleagues thought that was a great idea. And maybe because they heard me talking about this for 25 years, but they were really receptive and thought this was excellent. So having said that, in 2024, April of last year, the FDA approved the first handheld device to help assess patients with suspected mild TBI. So this is the point of care test that we were hoping to have. So you take a sample of whole blood and it goes on a cartridge and you measure GFAP. So the FDA indication is this was to help determine the need for a CAT scan in adults within 24 hours of injury in a non-penetrating traumatic brain injury with a GCS of 13 to 15. So that is the FDA approval for this device. So to determine whether a CAT scan is necessary, and it's usable within 24 hours. So in other words, is there a TBI or an intracranial injury or not? And so this is where we get into our clinical implementation. So we've gone all the way down the line of our model, and now we're at clinical implementation. So what happened when we implemented this? So in August of 2024, our emergency department actually launched this test clinically. So we're actually using it in our emergency department right now. And the FDA approved the cut points for these 2 markers. GFAP is 65 picograms per milliliter. UCHL1 is 360 picograms per milliliter. The sensitivity is roughly 97% with a specificity of 40%, and the negative predictive value is 97%. So this is a rule-out test. So this is like you would consider a D-dimer test. So this is a very good rule-out test. And so just to be clear, if the biomarker, this provides both a quantitative and a qualitative measurement of the biomarker. So you can see how much GFAP and UCHL1 you have, and you also get an indication of whether the test is elevated or not. So if both biomarkers are below their cut points, then it's considered non-elevated or a negative test. And that's where your CT can be ruled out. If any one of the biomarkers is above the cut point, then the test is considered elevated or positive, and a CT cannot be ruled out. And so this is how the test is designed. And so you can see here on the screen, the GFAP level on this particular patient was less than 47, UCHL1 less than 8. So both well below their cut points, and therefore it gives you a reading of not elevated. And on the other side, you see that GFAP here is really high at over 5,000, and UCHL1 is 1,700. And you can see that those biomarkers are very elevated. And so therefore, this test would be considered elevated, and CT scan could not be eliminated. In other words, CT scan would be required. And so we actually constructed an algorithm for our department when we started using this blood test. And so I'll go through it quickly. And so the first part essentially is you have a patient who comes in with a head trauma presenting within 24 hours of injury, non-penetrating injury. Patients who have a GCS less than 13 automatically go to CT. Patients who have a GCS of 13 to 15 and the physician suspects a TBI, we apply the clinical decision rules. And our preferred clinical decision rule is the Canadian CT head rule, because in our study, it showed that the CCHR in combination with the biomarkers had the best sensitivity and specificity. And therefore, that's our go-to clinical decision rule. And then for patients who are either a medium or high risk, a CT scan is recommended. And so those patients go to CT. In patients who are low risk, then it's up to the physician to decide. So if they're comfortable with this, the clinical decision rules, that they don't perform a CT scan. If they feel they need more information or they're a little bit uncomfortable with the interpretation of the CDRs, then they move forward and they do the point of care blood test. If it's positive, they get a CT. If it's negative, they can forego the CT scan. And then there's another group of patients who the CDRs are not necessarily applicable or haven't been addressed by the CDR. So patients who may be medicated or sedated, or patients who have a mixture of drugs and alcohol and really don't know how to interpret that half-life. A history of multiple head CTs where patients have come in and they've had already, a dozen CT scans, coagulopathies, patients who've had either a seizure or syncope prior to their trauma, if the mechanism of injury is not clear or the history is not clear. So that gives us an opportunity to use the blood test where we feel we may need a little bit more information. And so currently our management is GCS score, neurological examination, clinical decision rules. We now have the blood test, and then we decide whether we need a CAT scan. So we've come a long way. Since this, it's been a very exciting time for us. And so in terms of how it's impacted our practice, because it's a point of care test, our nurses actually do the test in the emergency department. So we were a little bit worried that they wouldn't be too happy with the extra workload, but they actually really love it. The residents really, really enjoy using it, and our attendings as well. We've noticed that our CT ordering rate has decreased significantly, and our throughput times have improved also significantly. So it's been a very positive experience from our point of view. Again, I just want to go back to those first two great debates that we had during my residency, which were the use of cardiac biomarkers. And you can see that troponin has been an ongoing biomarker tool over the last 50 years, starting from when it first came out in the 1990s, and then of course now with high sensitivity troponin. So you can see the span, and so we can see that similar span happening with traumatic brain injury biomarkers. You can see that it's only been since 2018 that we had the first FDA approved blood test for these two biomarkers. And now in 2024, we have a point of care test. So we can see that the evolution of these biomarkers continue. So we're really early on in the timeline of the use of these traumatic brain injury biomarkers. And just a reminder, it is only FDA approved for determining whether a patient could have a CT scan. It actually requires a CT scan or not. In terms of other indications, we're still looking at concussion and whether this can help determine prognosis. So we have a lot of research that's still ongoing. And so one of our future interests, of course, is children. So we're conducting studies in traumatic brain injury in children, and we're looking at the blood test in them as well, because it would be very helpful. And again, this is why we do this. There's so many potential applications for or the blood test, but we have to continue looking at this. We have to continue working and applying this at a clinical level according to the FDA approval. And it's all really, really very exciting. So I hope that we've given you a little bit of a glimpse into the history of these biomarkers and how we're currently using them.
Thank you, Dr. Papa, for that excellent presentation. There is no doubt that the research and publications and work you've done pioneering these biomarkers has definitely brought this to fruition, and you should be very proud. And we're really pleased that you've done the work that you've done. That combined with some of the work from the TRACK TBI consortium and researchers and the work from the DoD to help get this to market has been tremendous. And you helped get that momentum started years ago. And much like troponin, now we have a blood test for the brain, which as an emergency physician, I'm very excited about as well. And this will change what we're doing, not necessarily replace what we're doing, but as you mentioned, maybe complement our current clinical decision rules and good neurologic exam so that we can properly triage patients and do the right thing and maybe not order as many scans. And who knows what the future will hold as far as prognostication and recovery. Concussions are definitely something that's on everybody's radar, not only in sports, but even in the general public, which is where we see most of our concussions, right? They're from falls and not necessarily just from athletes. So lots of work still to be done. We're very excited and very pleased, again, that Abbott has this test now on whole blood, and it makes it much more practical at the point of care. So thank you for all of your work. Thank you for taking the time to share your expertise and your journey. It's been a long journey. And thank you all for your attention and attending this webinar. Hopefully it did answer a lot of questions, and sure you'll see more publications in the future. And now a lot of societies and guidelines are incorporating this into their recommendations now. So definitely a game changer. So thank you again.
Thank you. It's been a pleasure.